This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, I'm here with yet another interesting case. This is a case referred to me suggesting that it's a subluxated cataract for further management. Now, he is an 80-year-old man who has this cataract, which was preliminarily diagnosed as query subluxated cataract. The patient is not cooperative for examination, has got very deep set eyes, narrow palpebral fissure, doesn't open the eyes very well for examination. In preliminary examination, we can just see the nucleus sitting down, but carefully when we see, it looks like an hypermature cataract with all the cortex being absorbed and the bag looks to be still intact. It is just that it's an empty bag with just the nucleus around, and these specks on the anterior capsule are seen, again suggestive of a long-standing cataract. And in the areas where the bag is empty, it appears that the anterior capsule and the posterior capsule are fused together. So the diagnosis essentially becomes an hypermature cataract with an empty bag, and obviously the zonules would be suspect in this eyes because of the long-standing nature. Let's see whether we can save the bag and place a posterior chamber intraocular lens in this eye. The challenges would be, one would be to get the visualization right. So poor visualization because of the deep set eyes and narrow palpebral fissure. Number two would be, we expect a very weak zonular apparatus in these eyes. So there would be a chance that we may be at risk of losing the bag. So I have already have a backup iris clip lens ready for this patient. Needless to say, the antivitrectomy setup is also ready. Plan is to perform temporal sclerocorneal incision and then extract the nucleus manually and try to save the bag. I begin by making the conjunctival flap. I'm sitting temporally, and as I can note, the exposure is really not great. So that is one of the challenges, and always there's going to be pooling of the fluid, so I need to deal with it as well. I stabilize the globe by holding at this scleral groove which I have created slightly posterior, 1.5 mm from the limbus. The scleral incision is created measuring about 6 mm. Then a crescent knife is used to create the sclerocorneal tunnel. To aid visualization, my assistant is helping me out with the constant irrigation over the area to keep the blood away and also actively sucking the fluid using an aspiration mechanism so that the pooling of the fluid is prevented. The side ports are created and the anticapsule is stained under the air bubble. The dye is irrigated out, followed by injection of dispersive OVD into the antechamber. Using a 2.8 sharp keratome, which is bevel up, I enter the sclerocorneal tunnel, and the internal valve of the sclerocorneal tunnel is being created now. Care is taken to ensure that the inner lip always runs parallel to the limbus. The internal incision is around 1 to 1.5 mm from the limbus. This provides us the self-sealing sclerocorneal incision. Time to perform the most critical step of the surgery, that's the rhexis. And the moment I am touching the anticapsule, that's the time I will come to know the health of the zonules. So this is probably the most critical moment of the surgery. Let me pause for a moment here and try to show you the areas where I am expecting the anticapsule and the posterior capsule to be fused together. So my goal would be to first try to inflate the bag after making a puncture and just to see whether I'll be able to form the bag. So I make a nick with the 26 number needle and I'm raised a flap. There was not much severe wrinkling of the anticapsule, suggesting that the zonules could be reasonably well off. Now once I have the opening in the anticapsule, my plan is to inject OVD going under the anticapsule into the capsular bag and just hoping to inflate the bag in these areas. And thankfully, the plan seems to be working and the anticapsule and the posterior capsules are separated now and there is some sort of a semblance of capsular bag being formed in this area. So now with the bag being formed at least partially, now is the time to perform the rhexis. I'm stabilizing the globe using an instrument through the side port, and I'm using a forceps to perform the rhexis. The flap is grabbed, and as I'm trying to tear the entercapsule, I'm pleasantly surprised that the zonules appear to be quite healthy, and the tearing of the capsule seems to be quite seamless. And as I near completion, I suspect that it's extending towards the periphery, and I stop it at this place. I wouldn't want to pull it inside now, because in this long-standing cataract, the zonules might not be very healthy. So I thought I would just use the scissors to cut this flap. I'm using the micro scissors to do the job for me. The antercapsular flap is cut. Since the nucleus is relatively smaller and with the presence of a compromised capsulozonular apparatus, I just use the visco expression to extract the lens out. The viscoelastic is being injected into the antechamber, and at the same time I'm pressing the posterior lip of the tunnel, and the nucleus is gently expressed out. As there was hardly any cortex in the bag, I thought I just want to implant the lens and close the case. The bag is inflated with cohesive OVD so that the bag is deepened, and the planned PMMA lens is being implanted into the bag. The distal haptic is introduced under the antercapsular flap, and then the trailing haptic is gently dialed into the capsular bag. There's something suspicious here. These lines in the posterior capsule are probably indicative of a posterior capsular tear. At this stage, I'm not sure whether there is vitreous disturbance as well. I go in with my bimanual IA to remove this small bit of cortex here. I'm using a micro scissors to cut off this floating antercapsular flap. With the irrigation handpiece still in my left hand, I'm injecting diluted triamcinolone acetate through the side port just to rule out the presence of any vitreous prolapse. In a fraction of a second, it is quite evident that there is vitreous disturbance, and we can see this vitreous fiber sitting at the main incision. So the vitreous prolapse has occurred, and this is how it looks. The prolapsed vitreous through the main incision is first taken care by cutting it with the cutter itself. And now a bimanual antivitrectomy is being performed. As the vitrectomy is being done, because there is an egress of vitreous coming out, we can see that the lens moves around a little bit. Once I've cleared the vitreous from the antechamber, I'm inserting the same vitrector across the zonules and going into the vitreous cavity through the limbus itself. I'm very careful to ensure that the port of the cutter is facing downward so that I don't cut the posterior capsule which is in front of the vitrectomy probe. So I'm performing minimal antivitrectomy. Only the vitreous around the vicinity of the capsular bag is removed, and take care of some of the vitreous which is again come up. Once the vitrectomy is adequate, I can notice that the lens is settling down well, and in fact the equatorial tear of the posterior capsule seems to be diminishing in size. And with the irrigation handpiece still in my left hand, I'm using the lens dialer to dial the lens a little bit. Once I dial the lens away from this danger area, all the stress lines of the posterior capsule have disappeared now. So it was more of a equatorial tear or transzonular tear, because now once the lens is well settled and the vitreous is taken care of, I am not able to visualize that posterior capsular tear. There is a distinct pupillary peak at this quadrant, so probably there is an vitreous strand which is causing this peaking, so I'm going to take care of that single strand. In such a situation where there is only a single strand which is causing the pupillary peak, I usually change my setting to IA cut mode, and then I grasp the fiber and then cut it. This is one of the instances where I use the IA cut mode. Once that strand is taken care of, we can see that the pupil has now become round and the peaking has disappeared. The haptic of the lens is then dialed to ensure that both the haptics are away from the zone of the compromised posterior capsule. The lens looks to be very well centered and stable now. Point to note here that during all these maneuvers, I have never allowed the chamber to shallow. The the sudden decompression is not allowed at all. My left hand is always holding the irrigation on itself. Now I'm injecting intracameral pilocarpine to bring down the pupil. Again, the idea is not to miss out on any single strand which could be protruding out. As I'm sure now that the antechamber is totally devoid of any vitreous, it's time to close. Wounds are hydrated. And I'm going to close the conjunctival flap by using an atovicral suture, and the knot is buried in. These are the post-op pictures, and the patient did exceedingly well. The patient's vision was 6/9 and he was extremely happy. To summarize, this was a complex case, but we need to expect that these capsular zonal apparatus will not be the most healthiest. And if we are a little bit careful, gentle, and plan it appropriately, most often than not, we can save the bag and also deal with the complications if at all there are any. And eventually the outcome is going to be excellent in such eyes. Thank you for watching and hope you found this helpful.